they actually don't know how to regulate cell and gene therapy because it's not the same as drugs, right? Because you might have a high upfront cost, but you're curing a patient or you're putting them in remission. Like it's completely different from a pharmaceutical model where you have to keep taking something over and over.
All right, welcome back, beautiful people. I'm Dr. John Lakey.
And I'm Dr. Payman Danielpour.
Today, I'm so honored to welcome Dr. Adeel Khan. Now, he's not your typical Regen Med doc. He is the CEO of Eterna Health Clinics, which is, again, all things regenerative medicine, cutting edge, including genomics, gene therapy, and tissue engineering. He's the CMO of MiniCircle, which is just amazing reversible genetic therapy technology. The co-founder of Exalt, which is fitness and wellness. You know, again, I don't know how you do it, and also chief scientific officer at Science in Humans, which is a company that's dedicated towards hormone optimization and hormone treatment and therapy. And so, you know, you are definitely time bankrupt. And so I appreciate the fact that you are joining us today. So Dr. Adeel Khan.
Yeah, thank you.
Welcome.
Thanks so much. Yeah, it's cool because all those different businesses actually tie into this whole holistic health paradigm, which is actually shifting now, especially post-COVID, right? Everyone cares more about their health and longevity, and it's nice for everything to come together now. So
yeah, listen, you know, it's interesting to me because, you know, again, as a plastic surgeon, we think, you know, cosmetic surgery or reconstructive surgery, burn surgery, things like that. But regenerative medicine has played a role for a long time in fat grafting and in burn and cellular therapies and tissue engineering, things like that, to look at replacements, especially for our reconstructive cases. For you, it also seems to make sense. Sports medicine and managing pain, these are things where regenerative medicine is at the forefront. So tell us how you got here.
honestly, it was because I saw patients not getting better with the traditional stuff, or I just saw a lot of them just looking and asking for alternative options because they didn't want necessarily get surgery or get the cortisone shot. As you guys know, standard of care in orthopedic surgery, there's been lack of innovation, let's just say, for many years, because standard of practice is still, if you have an arthritic joint, which is where the cartilage starts to wear out, it's very much cortisone. It doesn't work. Then maybe hyaluronic acid, which is, a filler basically for your knee. And that lasts for 6 months maybe. And then if that doesn't work, or if that starts wearing off, then it's like, okay, well, joint replacement. And now PRPs could be becoming more common, but even platelet-rich plasma, there's so much variability and not, very mixed results. So that's kind of how I got into it. And I started out doing PRP because I worked with a guy who pretty much pioneered it, Dr. Anthony Gallia. He was the first one to really do PRP for sports medicine. He did it for Tiger Woods and a lot of other people. And he got prominence because it was kind of like, oh, what's this like blood spinning thing? And he was using it for musculoskeletal. But then it really got popular, obviously, after cosmetics, because when anything goes into cosmetics, that's when it becomes mainstream, I find.
So. Of course. And
yeah. So the vampire facial, I think, just made it PRP a household name now, and most people know what it is. So I think a similar thing is going to happen with cell and gene therapy, which we'll talk about. I think once the cosmetic applications really start to take off, which they are, most people won't start talking much more about stem cells, exosomes, gene therapy, and all this stuff. But honestly, like interventional pain, for example, like a lot of people shy away from chronic back pain because they can be difficult patients. It can be hard to treat. Results aren't that great. And then for me, it was kind of like a challenge. I was like, challenge accepted. And so I dug into a lot of the literature and just started traveling the world and working with different physicians, doing different things, and kind of was able to come up with a really unique approach of using biologics. So stem cells, exosomes, all these different things. And now I can treat chronic back pain very effectively. Whereas before, if I had just been doing cortisone or nerve blocks, it wasn't very satisfying, and most patients weren't really getting better, or if they were, it was very temporary. So this to me was just a much more rewarding job, and that's how I got into it. And then it just kind of grew because obviously when you start treating patients that other people don't really have the skill set for, you become very high in demand, and it's a scarce skill set too because it's a very, as you guys are obviously surgeons, I'm using my hands as well for doing very precise injections, and some of them, for example, like the vagus nerve, which is only a millimeter away from your carotid. You have to have very precise hands and good imaging guided skills and all that. So there's very few doctors who can do that type of stuff. So once you have a unique skill set, you can really differentiate yourself from the masses, so to speak. And yeah, and then it just grew from there.
Love that. And I know that you spent a lot of time, again, you're a jet setter. You travel the world between Canada, US, Mexico, Dubai, Lithuania, Japan. Kind of tell me, I know that you have a special interest, and passion for Japan. I mean, the entire culture and everything surrounded with it. But what did you learn there? When we look at, all of things, when we talk about regenerative medicine, tissue engineering, China tends to be probably the best in tissue engineering. What did you learn in Japan? Really, you brought back with you, and you're like, you know what? We have to continue this work.
Yeah, the way they grew stem cells. So they use something called a conditioned media, which just means they condition it beforehand with actual stem cells to enhance what's called the cytokine profile. So when you grow the stem cells, the cytokine profile is like the proteins. So the number one thing people need to understand about stem cells, especially umbilical cord stem cells and the sort of first generation stem cells, is they're signaling molecules above all else. And then, so the signals that they send is very important. And the question is, how do we standardize those signals and how do we control those signals? And that's kind of where we're headed now with designer stem cells. But basically in Japan, they figured out how to kind of grow them in the best way by limiting the number of passages, which is like how many times you replicate them, and then the medium you're growing them in. And then also they're the birthplace of what's called cellular reprogramming. So Yamanaka, the guy I like to mention on every podcast pretty much, he figured out how to take an old cell and make it young again, which sounds like science fiction, but it's basically the Yamanaka factors, which when you overexpress these 4 transcription factors, it can take any somatic cell in your body. So for example, a skin cell, and it can make it young again into basically an embryonic stem cell state. So it's like pressing the reset button, which is really cool. But the issue was always about forming tumors and cancer, and that's the issue with embryonic stem cells. So we'll talk about how we've overcome that challenge. But so birthplace of Yamanaka, so number one. And then number two, they also have birthplace of something called mu cells. So mu cells were also discovered in Japan. They're called multi-lineage stress enduring differentiating cells. So basically it's a mouthful, but mu meaning that so essentially what that means is stress enduring means that they can survive harsher environments, and they actually have more pluripotency. And we believe that, so they're a subtype, mu cells are a subtype of mesenchymal stem cells, which are the type of stem cells we get from umbilical cord or from fat or bone marrow. But it turns out that most of the benefits of mesenchymal stem cells is probably due to the mu cells, their subpopulation. Generally speaking, they only have 1 to 5% in most MSCs, but now we have technology from Japan that we have these cells that increase the mu concentration to 70%. And that allows for more pluripotency, better homing capabilities, better survivability of the cells. So we already have these engineered cells, and we're starting to use these engineered exosomes, and the results are just so much better. It's actually, and for cosmetics too, it's quite significant, because exosomes are a problem right now, topically, if you use them topically for cosmetic or for IV administration for anti-aging, they're cleared out by your body pretty quickly. They don't stick around very long. Whereas these mu cells, they're hypoimmune and they stick around longer, and they're also coated in this stealth hydrogel. It's a really cool technology that we're working with. But these were all born in Japan. And so that's why I'm just, I'm amazed at the Japanese and, almost kind of how it's hidden away from the world, because obviously there's a huge language barrier. And I just feel like there's all this amazing work being done on that side of the world, and no one's really bringing it back. And fortunately, just because my wife happens to be Chinese and her family lives in Japan, so I just happen to have a bit of connections there. And so I'm going to be spending the whole summer there this year and continue to do some research. And obviously I'll be treating patients there. But one of the biggest reasons I'm excited to be there for 2 months is just to keep on learning.
Before we get too far, if you don't mind, Dr. Khan, can we just really kind of make it as basic as possible and talk to our listeners about stem cells and just kind of educate them on what a stem cell is and why this is the holy grail in medicine now, and why we're really trying to use stem cells for a variety of different applications, because I don't think people really understand what stem cells are.
Yeah, I think people have heard the word probably in the news and stuff like that, because especially during the Bush era, when they're talking about stem cells and then they kind of banned them. And that was because they were embryonic stem cells coming from fetuses. And obviously there's ethical issues, not to mention the issues of potentially cancer. So a stem cell at a very basic level is just a cell in your body that has the ability to divide into different types of cells, so meaning self-renewal. and it can also turn into different types of tissue. So those are like the two basic principles. And the cool thing about stem cells is their adaptability, meaning if you put them in different environments, they can turn into different types of tissue depending on the local environment, which is what makes them really unique. So they're actually, and I don't know if you guys heard of Michael Levine. He's a bioelectricity scientist, and he's been talking about how cells are almost like sentient beings.
Yes, how we can turn on certain applications by delivering energy to certain areas.
Yeah, but it's almost like the cells know what to do if you send the right signal. And it's really challenging. This whole kind of, it's making us rethink everything what we knew about cells. And if you think about it, we have trillions of cells in our body. They're doing such a coordinated, complex processing. It's almost like maybe they do have some sort of inherent, ability to know what to do as long as you give them the right tools and signals. So that's why it's a very interesting concept. So basically, if we can isolate these molecules that can regenerate and repair tissue, as you get older, so when you're a baby, you have about 200 stem cells per cell. And by the time you're 80 years old, you have one stem cell per cell. So meaning it's gone down by 200 times basically. So the number of stem cells in your body has decreased in a very significant way, which means less repair, less regeneration, and difficulty because they're like the construction workers that are going to fix things. Whenever there's damage to the DNA or there's damage to the cells, the stem cells' job is to help repair and fix things. But as you get older, one of the hallmarks of aging is called stem cell exhaustion. So that means exhaustion, meaning that the function of what they're supposed to do decreases, but obviously the number is decreasing too. So they can't repair things as they should. And where is this very important? This is actually very important where your body has a barrier. So there's three main barriers in your body: skin, right, obviously, and then the blood-brain barrier, and then the gut lining, the gut barrier. These are areas where it's very important for stem cells to, it's not so much a blood-brain barrier, but gut and skin, because gut and skin are continuously renewing. They're going through this renewal cycle every like 3 to 5 days for the gut. And for the skin, it's like a week. So meaning you're continuously renewing and shedding cells, so to speak. And so that renewal process, a lot of that's mediated by stem cells. And so if your stem cell function has decreased and the numbers, and you can't renew, and then you can't regenerate and repair like you did when you were younger. So if we can hone this ability of stem cells to repair indefinitely, maybe we can really put a big dent in aging. And that's kind of the excitement around it.
Awesome. Thank you.
When we talk about stem cell therapy, I mean, listen, it's one of those kind of wastebasket terms, I think, now, because true stem cells, when we say, true stem cells, as you have said, really are these pre-progenitor cells that can differentiate into any different tissue type. And when you say, all right, I'm going to Panama, or I'm going to Costa Rica, or I'm going to Germany, or we're not truly getting stem cells. We're getting mesenchymal cells that are, they're basically, as you said, signaling cells. They've already differentiated into a certain type or a lineage, and we go from there. Maybe you can comment on that a little further.
Yeah, this is probably a podcast on its own, but I'll try to summarize the best I can, because the term stem cell has almost been abused. Because again, when marketers and business people get their hands on things, they tend to ruin everything for everyone. And that's just what people do whenever there's an opportunity. And unfortunately, stem cell industry is full of a lot of not so great people who are just trying to make money and patients, giving them hope and taking advantage of desperate patients. And that's why I'm trying to do this the best way possible, where I'm trying to offer what I believe is a very good treatment for many conditions, but at the same time, not giving false hope for patients that I don't think I can help. So there's a few things to understand. First is the different levels of potency, a potential to differentiate into different cell lines. So this is called, for example, if you have totipotent, a totipotent cell is a zygote, basically, which is when an egg and a sperm basically fertilize, and that's it can turn into anything, right? So that's totipotent. So we don't have it. Obviously we're not using totipotent because they can also turn into cancer or tumor, and that's a problem with the totipotent cells. Now the next level after that is called pluripotent, which means it can differentiate into the three basic cell lineages, which is ectoderm, endoderm, and mesoderm. And that's what we really want, because that allows for the most differentiated, most repair and regeneration. And that's what people think they're getting when they're getting umbilical cord stem cells, but they're not really. Like you said, for the most part, we're called multipotent, which means they can they have what's called a tri-lineage differentiation capacity. which essentially means they can differentiate into like cartilage, bone, fat, muscle, like just those basic lineages, which is still useful for cartilage, obviously, and for musculoskeletal issues. But it's not like by injecting umbilical cord stem cells, we can regrow you like new neurons or something like that. So that's where the limitation is with that. So what we want is pluripotency, not multipotent cells. So how do we, and so that's why the problem in the US, especially, you can search right now, stem cell clinic in the US, and you can probably find 100 of them in Beverly Hills. And, it's very problematic because they're not actually offering true stem cells. They're offering what are called committed progenitor cells is the correct term, which is essentially a signaling molecule that's being harvested from your fat or your bone marrow, and then it's being spun down and you're isolating some of the healing properties, which is still reduce inflammation, but it's not really a stem cell in the sense that it has the capacity to differentiate the way you think a stem cell would. So I think that's the biggest thing it's for people to understand is you want pluripotent stem cells. And that's why the mu cells are cool because they do have that pluripotency. But even better than that are engineered or designer stem cells, which are called the induced pluripotent stem cells or the Yamanaka stem cells, essentially. And then those are pluripotent, obviously, as the name suggests, and they have the ability to differentiate into all those different cell lineages, and they can be used to actually regrow new neurons, new cells, and engraft into tissue. So that's the holy grail. And that's where all the research
is hot topic. For all the listeners and viewers out there, you have to understand this is, it sounds sci-fi, but this is reality right now. So you had touched on it earlier. For those of you who don't know, Shinya Yamanaka discovered these 4 factors that were, I think, in 2006 or something like that, and ultimately are taking cheek cells, internal swabs, and using these Yamanaka factors to revert them, as you said, all the way back to their embryonic state. That kind of brings us into our next segue. These iPSCs, you were originally talking to me about, the second generation of stem cells. And that were these iPSCs, but there's something a little different that you guys do, or we have the capabilities now. And maybe you can go into that. I know that you had said that we're worried about cancer forming, tumors, teratomas, and things like that. Maybe you can talk about your iPSCs and where we're headed with these.
Yeah, so this is really where it's exciting, especially as a science nerd. It's amazingly exciting because we can basically take it as a platform technology, which means we can turn this baby stem cell, which we've taken from your skin or from someone else's skin if we're using a donor, and we can essentially turn it into any cell we want. We can turn it into cardiomyocytes for the heart. We can turn it into dopamine-producing neurons for Parkinson's. We can turn it into beta islet cells for diabetes, and so on and so forth. Or for hair, we're doing a hair thing too. We're going to make hair dermal papillae cells, so basically the progenitor cells that make hair follicles. And so we can essentially create whatever precursor we want and actually recreate new cells. And the tricky part is, like you said, how do we ensure that patients don't get cancer because they have that embryonic stemness to them? So number one, we have a technology called fail-safe. So the company we're working with has patented this, and essentially it prevents teratomas or tumors with this system that they built into it. It's a gene edit. So this is where it gets very sci-fi, where it's basically like we can control and basically engineer the cell to our specifications. And so number one, we make them to prevent teratomas or cancer by this fail-safe technology. And then number two, they're gene edited to be hypoimmune, because the problem with traditional cellular reprogramming a lot of times is that they have to go on immunosuppressants and they use viral reprogramming. So we're not using viral reprogramming. And so the big advantage of our technology is you don't have to go on immunosuppressants. They can cloak themselves from the immune system so they can engraft better, and there's no risk of cancer. So that's the big difference between the technology we're using versus most other iPSC companies. If you look up iPS, there's like 40 companies now doing iPSCs. It's going to be, but I believe it'll be like, I always say it'll be like Tesla, I think. It'll be a winner takes all. And, in like 10 years, I think it'll be like the kind of the biggest company that manufactures most of the cells for most of the world. And hopefully that'll be our technology. With the scientists who built it, they're brilliant. They work for so many pharmaceutical companies as well in the past. I just happen to identify. I think that's obviously one of the things is discerning what's the best technology because there's just so much noise in the space now.
Yeah,
and with this, is it directly injected into the area? For example, I know for years, and I know John was at the forefront of this with transplant surgery, where they were doing islet cell transplants into the pancreas. Now, when you talk about the iPSCs, do we directly put them into an area that needs repair, or is this like, okay?
There's going to be two approaches with these iPSCs. One will be direct. So, for example, we are planning to do a type 1 diabetes study, hopefully next year, and we're going to take those iPSC beta islets, and our interventional radiologist essentially infuses them via the artery injection into the pancreas directly. And the idea is to regrow new beta islets so you have insulin-producing cells, and you can get patients off insulin. And this has already been shown, by the way, with even regular culture-expanded stem cells with type 2 diabetes. And that shows you that all these chronic diseases and degenerative processes have a lot more to do with cellular dysfunction. You know, a lot of times they're just looking at the symptoms, right? They're looking at the blood work, but they're not looking at the underlying causes as to why this happens. So the fact that stem cells can help type 2 diabetes, again, it's like, what's the mechanism there, right? The mechanism has to do with cellular repair, reducing inflammation, improving insulin sensitivity, helping mitochondrial health, and all these things that are kind of the hallmarks of aging, and it's repairing those different mechanisms. And that's why stem cells can be used for so many different things. And that's why they also sound gimmicky, because they can be, because it's like, how can you use stem cells for so many different treatments? It's because it turns out that, hey, maybe the body is more interconnected than we thought. Maybe it's not a fragmented, isolated system-based thing that we were taught in medical school. You know, at least when it comes to degenerative chronic processes. I think we're learning that there's more similarities than there's differences between chronic diseases.
That's amazing. When we talk about different applications, I know that, you know, using some of these stem cells, we now are slowly realizing how important the gut is to the brain and to our overall health. Where do you see the future of iPSCs in gut health and essentially recreating that balance that essentially deteriorates as we age?
Yeah, exactly. And there's actually something called a stem cell niche that's inside of the gut epithelial lining that gets mobilized to help repair the lining. And over time, that becomes, the signaling gets distorted, those stem cells age, and they can't do what they need to. And to your point, what happens is you get what's called intestinal permeability, or the colloquial term is leaky gut, which most people have probably heard of. But the problem with leaky gut, as you guys probably know, is it allows things that shouldn't get through the gut lining to get through. And this includes what are called neoantigens, which essentially start stimulating your immune system. And then over time, you have this chronic low-grade inflammation and immune stimulation, and then that can lead to autoimmune conditions. And that's why autoimmune conditions, as you said, like the gut is really where it starts. And I think people don't realize that autoimmune conditions and immune dysfunction now, in terms of prescription drugs, generates more revenue than statins. So it's crazy, the epidemic of autoimmune conditions we have. So 27 billion is what Humira made last year.
Wow.
And you think likely it's from our diet. I mean, this is the foods the processed foods, and
I think there's so much information going out about that. But the problem is, doctors are the problem. Unfortunately, we're the problem, because if you go to your rheumatologist, they're going to be like, diet doesn't affect it. It doesn't matter. And that's still what they say to patients. So I don't know how we can change that, but it's really problematic. And I think they just need to accept that, hey, maybe we don't have the high level RCTs that you're looking for, but what's the harm in telling someone to just try to eat less processed food? And it's like, I still don't understand that. But anyway, so to your point, a lot of it has to do with the modern environment. And so the question is, how do we build resiliency so your body can withstand the environment? And that's what this regenerative medicine principles are all about. So what we do is we can transplant new stem cells into your body, and that can help to repair the gut lining. We've treated many patients with inflammatory bowel disease and get them into remission, for example. And then you can also transplant new microbes into the gut, the fecal microbial transplant, which is essentially a probiotic, but except you're actually having permanent microbes transplanting and not just transient ones that are gone after you stop taking the probiotic. And increasing microbial diversity, we know, is associated with longevity. And again, if you care about, for people who care about cosmetics, if you're going to slow down aging, it's going to make your skin look better. And that's just a fact.
Before we slide into the gene editing portion of it, I think for all our viewers and listeners, it's going to be really important for them to understand. Let's say they're going to a clinic and they're being offered stem cell therapy. What are some of the questions that they should be asking? Because ultimately, listen, I know that even in our clinic, we use a very specific lab for certain things. What are some of the questions that the average consumer should ask? Because they're going to see these pop up all over the place. From what I understand, there are two companies that are going to put out a total of 100 units, here in the US. And even though the FDA isn't super psyched about it, they have found ways around it, because of that. There's a recent lawsuit between the FDA and several physicians, and they have temporarily won in a certain aspect. So I think it's a very gray, nebulous area here. But what should the average consumer, if they go to their physician, they say, and the physician is offering them stem cells, what are some of the questions that they should ask?
And let's say the stem cells are strictly for longevity and feeling better. Let's not say we're treating anything.
The biggest question I think to ask at this stage is, are they actively involved in research? Because this is still a very new field in the sense that the translational medicine side is only starting to take off now. There's been clinical research in stem cells for decades, but the clinical translation of that research into patients has only really been in the last 10, 15 years. So it's still a very new field, which means that if you're not actively keeping your finger on the pulse, so to speak, of what's going on, your physician may not know the best processes or methods or technology on what to get you. And not only that, I feel like a lot of these stem cell clinics are mainly doing it for business and money. And there's nothing wrong with making money. I get it. You Americans like money, but it's just in Canada where our culture is very different in that sense. But it's really, I think for me, the biggest thing is looking for physicians who are actually trying to help make this field better, as opposed to just trying to make a dollar. And so I think if you're not involved in some sort of research or institutional research, then I think it's probably, that's the number one thing I would say. And then beyond that, it's hard because honestly, it's an unregulated industry because if you're traveling to get stem cells done, if you want the right stuff, you have to travel outside of the US. Unless, and so you're kind of in the wild, wild west because it's less regulated, obviously, in those jurisdictions. And I think the credibility and asking, it sounds simple, but honestly, asking around and like doing reference checks and like, don't just go there until you've asked and talked to a few other people about it. Or at least you've seen some people that you trust that have gone there. And you gotta be careful because a lot of these stem cell clinics also pay people to, make, or they basically to make testimonials. So you gotta be very careful.
Now, I've got a question for you. I was talking to someone about stem cells and they brought up a really good point, and I want to see what you think about this. If you think about our bodies, it's like a running hose, like all the blood that's being pumped through our bodies like a running hose. And we put in stem cells, let's say, whether it's hematopoietic or mesenchymal, whatever it is, about this much. Somebody's going to come to the clinic and say, hey, how is that going to really affect anything if I'm putting so little in this big hose that's just going through your body nonstop? How are those stem cells that are being put in or being infused going to help me and not just going to be lost in the shuffle and just going to get kind of hosed away?
It's actually very interesting. So intravenous stem cells, what they do, most of them actually get trapped in the lungs, something like 90% of them. And what happens in the lungs is there's something called BALT, bronchial alveolar lymphoid tissue, which is equivalent to MALT in the gut, which is the kind of the immune system where 70% of your immune system is based is in the gut. But you also have this kind of lymphoid patch in the lungs. And so it interacts with that. And that interaction is what's called immunomodulation. And that's a fancy term for basically saying we're re-educating the signals that your immune system is sending. And there's all these things like macrophage polarization, like Th1 to Th2 ratios, and like T cell suppress, upregulating T regulatory cells. But the gist of it for people to understand is essentially making your immune system more tolerant, which means it can help to regulate things. So you're less likely to have hopefully autoimmune conditions, but you can even treat autoimmune conditions. And as we all probably know, one of the biggest drivers of aging is chronic inflammation. Inflammaging is even a term used in the literature now. And IV stem cells, because of their interaction with the lymphoid tissue and everything in terms of what it does, is reducing chronic inflammation and is helping to shift your body from a pro-inflammatory state to an anti-inflammatory state. That's the cool thing about how they work. Now, to your point, though, what happens is a lot of these stem cells are lost or gone or cleared up by your immune system relatively quickly. And also, we're not controlling and standardizing the cells. And there's obviously variation with donors and stuff like that. So it's still very, I would say, crude in some ways, but it's getting more sophisticated now with cellular engineering. So that's what we're shifting towards. So we'll still have the first generation options, but the second generation options, we already have the mu cells now, which we talked briefly about, and then we'll have the engineered stem cells as well, which will be essentially engineered mesenchymal stem cells specifically to target aging by targeting like the inflammasome pathway. And they're called IMSCs, or induced pluripotent stem cells, that are differentiated into mesenchymal stem cells. It's a mouthful, but basically IMSCs. And that's I think going to be the future of anti-aging regenerative medicine.
Love that. Well, it's a perfect segue into the next topic when we talk about genetic engineering and gene editing technology. I mean, the fear for a long time was we change one gene, but who knows what happens downstream. And you have found a company that has a reversible technology, and it's not DNA editing, it's more of creating mRNA from what I understand. Tell us a little bit about MiniCircle, your involvement, what is available and what's coming down the pipeline.
Yeah, so MiniCircle to me is the birth of a new technology similar to CRISPR. And for those who don't know what CRISPR is, that was maybe 10 years ago it started taking off, but it was the first really at scale gene editing technology. And it's a platform, right? And CRISPR is very powerful. But the problem with CRISPR is you can have off-site targets, meaning if you edit the genome, you may do something you don't want to do, or like you said, there might be downstream effects of that we don't fully understand. So the beauty of MiniCircles, so the word MiniCircle comes from this bacteria called E. coli, and they have something called plasmids. And plasmids are essentially way to exchange information between bacteria. They're kind of like those cards you give out to exchange information, you know, and that's basically what plasmids are. And now you can take this plasmid, and it's, if you look under a microscope, it looks like a it's basically a little mini circle. And so that plasmid, it's easy to, plasmids have been around for like 2 decades. So none of this is really new. It's just what was new was a technology that the scientists at MiniCircle, they've been working on this for about 7 years now, and how they figured out to make the plasmid stay longer in your body. There's something called transgene silencing, which is essentially that the plasmid gets silenced by your nucleus within a couple of days typically. So obviously doing an injection every couple of days for a peptide or something isn't very commercially viable because no one's going to really want to do that for years. You know what I mean? So it took many iterations, but eventually we got to a point where the plasmid can stay in your body for about 18 to 24 months. And the plasmid, just to be clear, is not changing your genome in any way. All it's doing is inserting a gene from the plasmid. So hence why it's called gene therapy, because we are inserting a new gene into your body, but that new gene is on a plasmid vector, which is very inert, meaning plasmids do not have off-site targets, and they're also not immunogenic. So they don't migrate, and they're not going to do something to your immune system that we don't want it to do. And the same can't be said about the lipid nanoparticle vector that they use for COVID. So which was given to billions of people. So this is arguably much safer vector than the lipid nanoparticle vector.
That's a separate podcast in itself. It would have been great to have MiniCircle technology used for COVID.
They could have used they could have used a lot of better things. I just don't know why they didn't. But so for the MiniCircle, because people are always concerned about safety, obviously with gene therapy, the reason why it's very safe, so people understand, is all it's doing is inserting this gene, carrying, for example, like follistatin, which I'll explain what it is, and it's telling your local cell, so if we inject it into your muscle or into your fat, it's just telling that local cell, hey, start producing more follistatin. And then it starts producing more follistatin, and then that goes in your circulatory system. And then follistatin is a bioidentical peptide hormone that has been around, again, for over 20 years. Your body naturally makes it, and as you get older, the levels decrease, similar to testosterone, similar to many other things. And follistatin, the reason we want to increase your levels is because it allows your body to put on more muscle easier by inhibiting myostatin. And so myostatin is just an enzyme that sets a limit on how much muscle you can put on. And the other cool thing follistatin does, it reduces systemic inflammation. And as we talked about, inflammation is a huge driver of aging. And so we saw some very dramatic epigenetic age reductions in our clinical trial, on average 11 years for people over 60 with just one injection, and which is quite profound. Does that mean they're going to live 11 years longer? We can't necessarily say that because they're biomarkers. We can say is that people did put on more muscle, and that muscle we know is going to add to health span and better quality of life. We all know that. That you
Increased
can't
bone
argue.
density,
Exactly, increased bone density, and
ultimately
that's why to me it
increased
always comes back to
metabolism.
first principles, because the biggest problem with longevity scientists, include like all the popular ones, is they're scientists, they're not clinicians, and they don't have that. Because I'm a clinician scientist, I kind of have both hats, and I can kind of see what is a clinical application here and how's this going to help my patient versus just looking at mechanistic data, which is what these scientists geek out about for hours, but then they don't actually talk about anything clinically relevant. And it's like, what's the
True.
point? Like, who cares? Like I care about I care about mortality. That's what we're always taught. And if I can put more muscle on your body, I know I am going to decrease your mortality in the long term.
Now, question for you. If this works so well, have you been using it for muscular dystrophies?
Yes, FSHD. We just started a clinical. We're doing case reports right now. So facioscapular humeral dystrophy is a common muscular dystrophy, and we've done it for about 4 or 5 patients. We're just starting, but we are going to be doing a clinical trial, potentially with Chip Wilson, hopefully. So we're just chatting with him and stuff like that. But yeah.
That's awesome.
And from what I understand, the next one down the pipeline is that Clotho.
Right. So the pipeline is very exciting. Clotho is this amazing. If you PubMed Clotho, you'll be. I mean, I was blown away by the research on it. It's a pretty amazing peptide that was discovered accidentally, I think, at Harvard, which is always interesting how these things are discovered accidentally. But
I love how they stumble onto it.
yeah, exactly. Yeah. So, but it has this. So Clotho is again is it's a naturally occurring peptide in your body, and so what happens as you get older, the levels decrease, and it turns out people who naturally have higher levels of Clotho are protected against Alzheimer's, even if they have the gene for it, which is really cool, like significantly protected from it. And also, people who have Clotho live longer, 30% on average, who have higher levels of Clotho, and people who have higher levels of Clotho on average have higher level of IQ by 6 points. So we're hoping that by optimizing people's Clotho levels to youthful levels, we can potentially increase their IQ, make them better brain health, and obviously prevent neurodegeneration. So we'll be measuring IQ in the clinical trial, so it'll be interesting to see. But at the very least, it should improve epigenetic age by quite a bit. Like it should have dramatic reductions in slowing down aging as well.
Very, very, very exciting. And then down the pipeline, you'll have other peptides that you're going to use.
Yeah,
as well.
exactly. And just to, I should have probably defined this at first, but a peptide, just so people know, is just a chain of amino acids that makes, and essentially insulin, for example, was a peptide made 100 years ago. So most people know about insulin. Now we just have designer peptides. And I think most people have probably heard of Ozempic because it got really popular. But there's so many different peptide targets that we can make. And the one I think that's going to make us mainstream and perfect for this podcast is GHK, copper peptide gene therapy. So copper again, it decreases as you age. And copper is very important for keeping the elasticity in your skin and helping with collagen production. So we're hoping that in the clinical trial, we'll see some dramatic changes in the skin, but also, again, slowing down aging too. Because copper peptide it's kind of like a bioregulator too. It acts on a lot of different genes and has all these benefits throughout the body for oxidative stress and inflammation. So it's a pretty powerful peptide. And I think and the other one I'm very excited about is OSK. So OSK vector is basically the 3 Yamanaka factors. We don't put the fourth one in C-MYC because that one can be associated with teratogenicity, basically a cancer and tumors, whereas the other three don't have that. But the other 3 are essentially used to reprogram cells and make them younger. So we can inject. So one of the trials we want to do is we want to inject OSK directly into the skin, into the vectors, and then you can actually make the skin younger.
So we were just talking about how you're going to bundle all these together, which is really fascinating because originally I didn't know anything about this gene editing or mini circle technology. I thought you were going to actually go in and fix someone's genes and edit them like that. This is fascinating. No, that's CRISPR, exactly. And to be honest, CRISPR has not been able to do some of the things that it's supposed to. So people are it's fallen short. This is completely different. And it's really fascinating because what you've discovered can really work. Instead of changing, you're adding or you're making it better.
And there's a kill switch, God forbid.
And that's the beauty of it because it comes from E. coli. You can basically take an antibiotic called tetracycline, like doxycycline, for example, and it will automatically get it out of your body. So for whatever reason, if you don't like how you feel on it, you have that reversibility, which you don't get with viral vectors, which is there is a viral vector company out there that's doing something similar as us, but obviously viral vectors can't be reversed. They're permanent, and there's always risk with viruses in terms of handling and all that stuff.
And how often does this have to be done? So let's say I'm interested in this because I'm 50 years old, and I know that over the next 40 years, I'm going to have muscle wasting. There's going to be sarcopenia regardless of what I do. It's just a part of aging. How often do you recommend this once you have this, completely figured out?
Yeah, no, we've done it for almost 700 people now. So it's not like it's been done for thousands, but that's a large enough cohort and of people of real world evidence plus the clinical trial that we did that we can say that, hey, this is very safe. Number one, there was no adverse effects that we've seen so far. And number two, in terms of longevity or duration of results, usually it's going to last 18 to 24 months. Some people, there might be some variation. Some people may silence it earlier, but on average, we usually tell people at least a year and a half in terms of how long you should feel the effect, which is pretty long. Yeah.
Significantly longer than Botox.
I'm kidding. With this, I have two questions then, because I know that kill switch using doxy or tetracycline, is it susceptible to any other antibiotic? Listen, when we have post-surgical infections and things like that, something that would treat E. coli, is anything going to kill that, or it's very
It's
specific?
not going to kill it, but it could decrease the kind of the expression of it. So meaning if you took like a broad spectrum, maybe like, Ceftrax or Clavulin or something like that, it may decrease a little bit of it. And that might be one of those things you just have to see and the good thing about follistatin in general is that people do feel a noticeable difference, meaning they do have more energy, they have more strength, they literally feel they can see their strength go up and all that stuff. So objectively, you can see the difference. And so if you were to do something that might affect it, like take an antibiotic, you'll usually notice that. So you can tell that way, because measuring follistatin levels is really cumbersome still. It's like an ELISA assay, which takes 12 hours and it's not very accessible for doing a blood test for everyone. Yeah.
Now, the study that you were talking about with the 700 people, is this geared towards disease or just healthy people?
So the clinical trial, just to be clear, was about 50 people, but the people we've given it to just outside the trial, and real people who just want to do it, because it is a commercially available product. We're offering it in jurisdictions that allow it, for example, like Dubai, Mexico, and Japan, and we're actually doing it for a commercially. And so, in terms of the administration and in terms of doing it, it lasts about 18 to 24 months, and it's we haven't seen any side effects. And the good thing in all the hundreds of people I've done it for has been just the reproducibility. I'd say maybe because people are like, how do you know it's it's going to work for everyone? There's been maybe 2 people I can think of that didn't respond to it. Like, it's very few people, and why they don't respond to it, our theory is probably because they already naturally have high levels of follistatin, and they probably the body's already making enough, and they're already saturated, and maybe that's why they're not responding. But we've also had some hyper responders who literally, we had like an 8-year-old patient who said he felt like he was 18 again, which was insane.
Wow.
Yeah,
that's amazing. And this is an IV therapy, right? It's just an IV therapy.
Just an injection.
Intramuscular or subcutaneous.
So that's right.
It literally takes 2 minutes. It's pretty unbelievable. Yeah.
This is fantastic.
The second question I had, because a lot of clinics here are starting to look at plasma exchange and that type of therapy. I know that they're touting that they are reducing the amount of LPA and triglycerides and things like that. Would it also lower the count of follistatin if you're doing any type of plasma exchange therapy? I don't know. It shouldn't. Your cell, because your cell's expressing that. It's like your cell becomes a factory for it. Mm-hmm. So unless you do a fat, unless you do a liposuction or you do a muscle biopsy and you cut it out, that's going to continue to produce the signal for the follistatin.
And and just out of curiosity, if someone's listening to our podcast and is very interested in this, they can really only get it in your clinic in Canada.
Well, we're doing a phase 2 trial in Canada. So for the phase 2 trial, it's actually specifically for sarcopenia. And that phase 2 trial is starting in the spring. So you'd have to be a Canadian resident to be in that trial. But so you could only get, if you're an American, the only place you could get this right now is in Los Cabos in Mexico, the closest place you could get it. We also do it in Ruatan, but obviously Mexico's much closer. So yeah.
That's excellent.
Now we had spoken before. I find this so fascinating. You were talking about, and I think you had talked just a little while ago about future potential for skin. You were looking at doing a clinical trial for cosmetics, for looking at dermis, and I wasn't sure if it was just dermapapillae, or if you were looking at a particular signal, LEF1 or something like that.
Yeah, no, I mean, I think the skin is underestimated in terms of being, because it's the largest organ in your body. And I think it's underestimated in terms of the importance of longevity. It's not just for cosmetics. I think if you keep the skin cells healthy throughout your body, it's going to keep that barrier as strong. And is that renewal system, which ultimately helps to regulate your immune system. A lot of this comes down to immune dysregulation in terms of like chronic disease and aging as well. And so if you can keep your immune system robust and resilient, and by one of the ways to do that is keeping your skin and it's like not just aesthetically good, but the actual skin aging, which is why I like these therapies, because unlike Botox, Botox is great, right? It does what it does, but it's not doing anything for the skin cells. It's not making the cells healthier in any way. I'm always about how do I make my cells healthier? So this stuff can make your cells healthier because they make them younger. It helps with mitochondrial dysfunction. It helps with telomere length. It helps with all these different things that cause the aging of the cells themselves. And, I was reading this quote. I think in 1 square centimeter of skin, you have 100,000 skin cells. So just 1 centimeter. So it's like you have so many skin cells throughout your body. It's unbelievable. And so maintaining that organ, I think, is very important, the organ system of the skin. And that's where I think copper peptide gene therapy will be very valuable. And I also think stem cells in general, intravenously and doing them on a regular basis, can be valuable for your skin, because it's going to help because the skin, we talked about, it goes through this really fast renewal process, right? It's continuously shedding and continually regenerating. So if you have a better stem cell function and you have a better efficacy of those stem cells, then they're going to be able to maintain and keep on repairing and regenerating that tissue.
Now, interesting. You said you should continue to do that. Now, big question. Better to take your stem cells from yourself or off the shelf?
If you're younger.
Doesn't matter how old you are. No, I'm just saying, it doesn't matter how old you are. Let's just say you're in your mid-30s. So you're right in the middle of where that decline is going to happen in the next 10 years, right? With your stem cells, with your telomere lengthening, everything. So what are your thoughts about that? I'm just curious.
Yeah, no, it's a good question, because after age 40, you definitely do have accelerated what's called stem cell exhaustion, which means the stem cells that you're harvesting aren't going to be very useful. But even at age 30, honestly, at any age besides being a baby, like why take your stem cells, which have gone through all this stuff, versus if you can have a standardized allogeneic source off-the-shelf product, because especially now with the engineered stem cells, because they're engineered to be hypoimmune, which means they can stick around longer and do what they need to. So to me, if you have an off-the-shelf product, especially the more sophisticated ones now, they're going to be much more beneficial because they're going to have a better profile, meaning they're going to have more anti-inflammatory signals, they're going to have more growth factors, and they're just going to have more useful stem cells in your own body, even if you're young. So using umbilical cord stem cells to me right now is still superior to using your own, but I think the engineered stem cells are going to be even obviously better.
And umbilical, versus, I guess umbilical and mesenchymal will be very similar, but versus hematopoietic, do you believe that we should mix them all as a cocktail? Because each one of them has their own kind of place for...
Well, it depends so I think the problem with hematopoietic stem cells is obviously the HLA matching. So you need, whereas the good thing about mesenchymal stem cells is they have very low levels of expression of HLA. So meaning that's why you don't have to have an exact match, and which is why you can do infusions to people who aren't, and that's why we don't have to check for matching. So that's the beauty of umbilical cord stem cells, is that their applicability and scalability. And I think you can still have what's called MHC mismatch, which means that they're still, and that's why they are still a little bit immunogenic, which means they get cleared up by the immune system pretty quickly. And that's a recurring theme I keep saying, which is why the second generation stuff is so exciting, because they're hypoimmune and they're cloaked. I like the analogy of, you guys ever seen Harry Potter?
Of course, the invisibility cloak.
Yeah, the invisibility cloak. Yeah, exactly. So that's what we're doing now to these stem cells and exosomes. We're basically cloaking them in these smart hydrogels and genetic engineering and they're getting cloaked from your immune system. So then your immune system can't clear them up as quickly. So they can do more of their good stuff.
Following up to what Dr. Davenport is saying, listen, we obviously have 2 cell lines. So one for everything immune, one, as far as our hematopoietic line, and then one for structure and function. What are the thoughts of, again, using, because I know Japan and China, they still do autologous. So it may be Neupogen induced, but they do Neupogen induced autologous HSCs, and then as a primer for the immune system, and then give these, what would be eventually these next generation iPSCs or MUs or IMSCs. What are your thoughts on that as far as, obviously the body has 2 cell lines. And so we know that the MSCs are structurally more powerful, they're non-immunogenic. But if let's say you were boosting the number of your own, what are your thoughts on using both?
Yeah, no, I think if you're trying to boost, I think that makes total sense. I guess a lot of the work I've seen too is in South Korea. They've been using umbilical cord stem cells a lot over there. And I guess we don't really know the answer in terms of which is the best. And I don't think we do. Because even with bone marrow, some people are using bone marrow culture expanded stem cells because they say they're potentially safer than umbilical cord stem cells. I don't know the complete answer to that. I haven't personally seen any major side effects of umbilical cord stem cells. But that's also because the way we manufacture them and we're in control of that. I think the issue comes in when you're not really sure who's manufactured them or how they're manufactured and all that and all those details. It is a little bit of wild west still, and that's why I think the biggest issue in this whole field is cell standardization. So how do we standardize a cell population so that we're using the same thing every time and we can have reproducible results? And I think that's why I think engineering cells is going to be the future, really, because then we can create what we need for whatever problem we're trying to solve. Which is why it's so exciting. We're just on that cusp right now.
And do you think I know you can't answer this because it's kind of impossible, but do you think when that happens and that standardization happens, you think that's when our governments, meaning the Canadian government and the US government, is going to open up and be a little more lenient? Because these can change, morbidity, mortality, life expectancy, just everything by such a dramatic amount that it doesn't make sense that there's such restrictions on it, right? When do you think we're going to actually be able to do the same things that we're doing across the border in Mexico, right in our own home?
Yeah, I wish I had a clear answer to that. I think the politics, unfortunately, it's more politics than it is medicine, and a lot of it has to do with lobbyists. And essentially, I think we need our own lobbyists. I think that's the solution. You got to fight fire with fire. I believe that what I want our company to do personally is become a big institution in a sense where we're doing lots of research, we're really moving the field forward, and we're showing the evidence, and then eventually we can hopefully sway the government to get approval for these things. I'm sure there'll be other people doing that too, but I can see as more European countries approve this stuff and EMA and stuff like that, I think there's going to be more pressure on US and Canada to do it. Although FDA and Health Canada are probably the most archaic, I think, with their regulation.
True.
And again, this has to do with because they don't have a regulatory framework for this stuff. They actually don't know how to regulate cell and gene therapy because it's not the same as drugs, right? Because you might have a high upfront cost, but you're curing a patient or you're putting them in remission. Like it's completely different from a pharmaceutical model where you have to keep taking something over and over. They don't know how to deal with this.
That's a big hit to big pharma. And so I'm imagining, that's why they're pumping the brakes.
Well, exactly. They're going to push it as far as they can. And I think sooner or later, people are waking up to it already. I think our medical tourism, I think at one point was even I was kind of like, what is this? It seems sketchy, But now it's becoming almost like normal practice for a lot of patients because they know they can't get all the best technology in US or Canada.
I know you also are involved in doing all of these cool different treatments. So it's not just regenerative therapy. It's not just, delivering exosomes and stem cells and gene editing. You do some other things. I know that, we're talking about for all the patients out there who, to be forever young, you have to be mentally stable as well. And I know that you're treating depression and anxiety and all these things. using the vagus nerve and what's called a stellate ganglion block. Maybe you could kind of tell our viewers and listeners a little more about that.
So to me, yes, this is very different from stem cells, but the principle is the same, which is how do we get your body back to a previous state? And that's the whole concept of regenerative medicine, right? It's like, how do we repair or fix something to the way it was before? And how do we get your nervous system back to the way it was before? Because we know nervous system is where a lot of trauma is held. And trauma, as you guys probably know, there's a good book by Paul Conti, who's a psychiatrist, and it's basically all about how our nervous system is where it's stored, and most anxiety and depression is actually rooted in unresolved emotional trauma. So, and a lot of people just don't have ways to deal with that. Therapy and whatnot can help, but it's not always effective. And so you have a lot of this population out there with mental health disorders that are refractory essentially to the traditional model, and they're left with no options. And this was highlighted to me when I always tell the story of this special forces operative who essentially served our country, did amazing work, and has really bad PTSD, and he failed the medications, and so they offered him medically assisted suicide. Tragic, right? And he has four kids. He has four kids. He has four kids and a wife, and it's just like
I love that was the option. Jeez.
Yeah, exactly. Yeah, and that's what they're doing here in Canada, right? So it was heartbreaking. And so I'm not a psychiatrist, obviously, but I was kind of reading about the literature on interventional mental health, and there's actually a lot of cool literature out there about interventions that you can do for people in these situations. And obviously, stellate ganglion, which has been around for 20 years, is where they put anesthetic into the sympathetic ganglion chain, which is around your neck here. And essentially what that does is it calms down your nervous system, but it only lasts for 3 to 6 months typically. So being a regenerative medicine doctor, I was kind of like, how do I put a regenerative medicine twist on this where I can make this last longer? And so I played around with a few things and tried out a few things. Obviously, you have to self-experimentation on patients and whatnot. And eventually I got to a point where we figured it out with exosomes and peptide and the right peptide formulation. We could really change the nervous system physiology, meaning we could change the signaling of the vagus nerve, which is kind of the gateway into your relaxation system. And it's almost a reset or reboot of the nervous system where people feel completely different after the procedure if trauma is the underlying cause. Obviously, if it's not related to trauma, this procedure may not help as much, but it can still help with general inflammation. But for trauma, it's unbelievable. That patient in particular, he started crying 10 minutes after the procedure. My friend was with him, so he told me in the parking lot, and he said it changed his life. And this was immediately after, and then it's been sustained, which is the beauty of this procedure. And now he's playing hockey again. He's back to a normal life, and it's just amazing that something so simple could make such a profound impact on someone. And I've obviously gotten a lot of attention for this now, and I have a backer who wants to fund a clinical trial for us for this procedure, which is great. So we'll probably be doing a phase 1 trial later this year for the vagus nerve as well in Canada. And because the goal is eventually I would like this to be covered by Veterans Affairs or something like that. You know what I mean?
Sure. Have everyone get potential treatment or at least access to it.
It's like such an easy intervention, and it'll make therapy more effective because you have a better mind-body connection. Your nervous system's calmed down. It's more regulated. It's almost like a no-brainer, right? To me, it's like it should be available to everyone.
And this was a one and done for this guy, or he came back for more?
Still good. That was like 8 months ago now.
That's awesome. That is fantastic.
Congratulations. That's phenomenal. I don't know.
It's nice thinking out of the box a little bit. Nice.
Listen, I think you're particularly gifted in that. One, searching out companies and vetting them to make sure that they actually work. And two, seeing the vision of, putting all of these things together. I mean, you're honestly recreating a new human. I mean, the idea is from head to toe, gut to brain,
modifying, adding genes, adding microbes, adding cells, reprogramming the nervous system. It really is. And honestly, it's funny you said that because I've had, I can talk about this publicly because he'll be posting about it soon, Zac Efron. And he had that type of experience. He felt like a new human afterwards. And he literally said because of everything he's gone through and just being in the industry for so long and just obviously mental health stuff there and whatnot. And it's just like, he literally said he feels like a new person. So
that's amazing.
Great, man. That's wonderful.
Going on to one more, essentially, organ system. I know we keep dancing around it. We've talked about the gut-brain health and issue and how important it is. I know, listen, poop pills have been, a topic of discussion for a little bit. Fecal matter transplantation. you had alluded to it earlier, ultimately, because we're repopulating the gut, ultimately eradicating autoimmune diseases, improving, eliminating brain fog, improving cognition. Can you talk about this therapy? I know that you're pretty passionate about it too, and I've heard you talk about it with Dave Asprey and Ben Greenfield and stuff like that, and maybe you can.
Yeah, to me, it's a low-hanging fruit. If you guys have hopefully seen the theme of a lot of my interventions, they're low-hanging. I'm always trying to target something that can have a big impact on the body. And so I believe the gut is another, obviously, thing that if you intervene in the right way, it can have a huge impact on the body. And so and that's what got me interested in it. And obviously, like you said, there have been FMT clinics all around the world. And there's even a place in California, I think you can get FMT via colonoscopy.
Uh-huh.
It is quite expensive though, but ours, but the technology has improved where you can transplant these microbes into your gut by just taking a pill. So you don't have to do it. Historically, you have to do it through colonoscopy, which is obviously somewhat invasive, and sometimes it takes multiple sessions, and obviously there's risk of colonoscopy, whereas this is just literally a 2-week course, and it's repopulating your gut with the same microbes. And there's been trials comparing pills to colonoscopy, and it shows equally as efficacious. So this is a much less invasive way to do it, and again, it's scalable, can help a lot of people, and there's very little downside. Typically, the worst case scenario with it is going to be it doesn't make a big difference, especially if you're doing the donor selection and all that properly, which is why I wouldn't do it myself. Obviously, I have a scientist who's a PhD in microbiome, and she's the one who's doing the whole manufacturing of it, because this is her life's work, basically, and she's putting it into a pill. And the coolest thing that one of the coolest products that we're going to make with FMT is we're going to take one of my Olympic gold medalist patients, and we're going to use his poop to transplant into other people like myself. And it can actually
He's the golden
I see some Olympians.
It actually improves your cardiovascular fitness. There's a trial done on that. It took
Come on.
I know.
Oh my
Crazy,
God.
right? And there's a trial. It's called OLP01. They took a Taiwanese gold medalist who happens to be a microbiologist, and they did a study with her, and they showed that you can increase people's cardiovascular fitness by transplanting new microbes. I believe FMT in 10 years will be the most prescribed drug on the planet because of its ubiquitousness. It can treat obesity, it can treat chronic illnesses, it's maybe not a standalone treatment, but it could be a part of a protocol.
And these pills are basically just going to be microbes, right?
Yeah, that's all they are.
That's it.
And if you listen,
no actual poop. Yeah, there's no actual poop.
Yeah, exactly.
No, that's what I want them to understand.
For the listeners and viewers.
You're going to take a pill of poop?
But it's not really that part is all, yeah.
I'm imagining that it's doubly wrapped. For those listeners and viewers, it's essentially encapsulated multiple times, and that's why it's not chewed up in the stomach, and it goes all the way to the large intestine. And that's what again, it's not going to be as gross as it sounds.
Exactly. It's just microbes. Yeah.
That's smart. That's fantastic.
Kind of one of the last things I wanted to at least talk about. Obviously, as plastic surgeons, we are extremely interested and passionate about wounds, scars, skin, because to us, the funny part is everything you're doing, we know is going to improve the inside, which ultimately indirectly improves the outside. But it's amazing how the general public is only concerned about the outside. And, obviously you're doing some research in that direction. And we had talked about, potential clinical trials and things like that. What do you have coming, in the near future that's just for skin that we need tested?
It's already available at our clinics at the moment, but we need to obviously we are starting a phase 1 trial in August for it, which is the engineered Muse exosomes. So the Muse cells I was talking about earlier. The reason why these are so much better than regular exosomes is because of their pluripotency of the Muse, and their also ability to survive longer. Because I think everyone knows exosomes are great, but the problem is they get cleared up so quickly that they can't actually do what they need to. So now with wound healing, with scarring, because one of the biggest kind of functions of exosomes and stem cells in general is antifibrotic, meaning it helps with fibrosis, scar tissue. It helps to accelerate wound healing. So this is where I see these engineered exosomes shining really above everything else, because you can always argue that maybe there's some risk with cells, but with acellular products, there's really no risk. And I think that the fact that FDA is regulating them like a drug is absurd. And to me, it should be following Japan's framework, which Japan has a framework of regulating exosomes differently from regulating stem cells. So they don't have the same regulatory scrutiny as stem cells, and they should be more permitted. And that's the model they should follow, right? And again, Japan has already done it. US could just copy it. It's not hard.
Yeah.
And so
right,
but they just refuse to. So anyway, so for now, you still have to travel outside the US, but we are planning to do a phase 1 trial, and I definitely want to explore more in terms of skin applications and cosmetics for these engineered exosomes, because I think they're just going to be so powerful, and they're going to be a game changer for the whole cosmetic industry.
And would these be used topically, or would they be microneedled or injected?
You can do both. So you can have a topical solution. Obviously, you can keep in the fridge for a couple of weeks, but you can also, the main purpose will obviously be coming to a physician office and getting them injected. You can do micro needling, and then you can do for areas where people tend to have more deeper wrinkles or areas of concern. Then you can inject with like a diabetic needle, so you go a bit deeper, because it can also stimulate collagen production.
Yeah.
And in Japan, again, I keep bringing up Japan. Sorry, but I work with the plastic surgeon in Japan, and she's the one I'm working with actually in the summer, Dr. Midori. I'll introduce you guys if you want. She's brilliant.
Awesome.
But she's such a great plastic surgeon, and she's been doing these facials for 10 years now using stem cells and exosomes. And she said she stopped using Botox, and because it lasts for 2 to 3 years, and the results have been great. And you're actually slowing down the aging process, right? As opposed to just like masking it. So it makes a lot of sense to me.
If you like this video, you're going to love this one.
We live in the most toxic environment that humans have ever lived in. How do we apply the Pareto principle to detoxify 80% of your life? We make that happen for people. Once you do that, not only do you avoid disease, but you start feeling incredible too.